Good evening and welcome to our Women and Heart Health webinar. Thanks for joining us. I'm Dr. Bonnie Bowles, the Chief Medical Information Officer with Tanner Health System, board certified in pulmonary, sleep, and critical care medicine. But more importantly, I have with me Dr. Onaje Greene, who is board certified in cardiovascular disease with Tanner Heart and Vascular and is our Director of Non-Invasive Cardiology. So we're really excited to have Dr. Greene and to have this topic because it is Happy Heart Health Month. February is a month designated as the American Heart Month, while the nation is reminded to focus on the health of their hearts. And Dr. Greene is going to help us with that. So, Dr. Greene, I want you to tell us a bit about yourself and your training, how long you've been with Tanner, and then I'll let people know how to ask questions and we'll get started. So go ahead, Dr. Greene.
Hi, good evening. Thank you, Dr. Bowles. Again, it's a pleasure being here for the Tanner Medical Center Live Well educational series. Again, we're doing Women in Heart Health. Again, I'm a transplant from New York originally, and I've been down here in the West Georgia area for about 14 plus years. I did my training in Maryland and DC area prior to coming down to the West Georgia area, and it's been a great experience being here. And again, it's always a pleasure coming out to talk and educate the public and spend some time just going over things in terms of cardiovascular health.
Great. Well, thank you. We are glad you're here. So could you show us that second slide? Do you have the slide control? And by the way, we are in separate rooms. That's why we are able to take our masks off. So how about the third slide, Dr. Greene? Thank you. Sure. So this is how to ask a question. Oops, could you go back one? Press the purple Ask a Question button on your screen, and once the box appears, you can type your name if you like, or you can leave it anonymous, and you can ask a question or make a comment. We'll try to get to all of your questions and acknowledge your comments, but we probably will let Dr. Greene get through the presentation before we get really into the questions, because he's going to answer a lot of your questions during his presentation. So let's kick it off, Dr. Greene, with what is cardiovascular disease?
Well, yes, thank you. So cardiovascular disease is any condition that involves the heart and the blood vessels. As we know, cardiovascular disease affects the circulatory system, and unfortunately, it's the #1 overall killer of Americans. It kills actually almost twice as many when you compare it to cancer. And it can be a chronic disease. It can often begin at an early age. I've had patients as young as 20s, 30s that we have to take care of with cardiovascular disease. And unfortunately, more Americans die each year from this than anything combined. So again, it is a national concern in terms of cardiovascular health, and it definitely the economics behind this, it does definitely strains the financial system. So being more preventive strategy is a big part of what I try to entail to my patients.
Thank you. And so just looking at the mortality and going over that with us, and could you comment on, in addition to that, why is heart disease increasing in the United States?
Well, I think a big part of it is our lifestyle, that nowadays we become more sedentary, and again our diet has changed as well over the years. So I think it's a twofold, where we become more sedentary, or we've had poor diet, unfortunately, and with that comes the weight gain, and then that increases your risk of having risk factors such as having more high blood pressure, more diabetes, high cholesterol, and so forth. And as I'll talk about later, those risk factors actually increase your risk of cardiovascular disease. So you can see from the slide here, those with, you saw the USA is almost at the top of the list here in terms of mortality rates with cardiovascular disease. And it's because we often have higher cholesterol, more sedentary. And then when you go down here to Japan, Greece, France, they have much lower rates of cardiovascular disease because they have they actually are more active and less sedentary, as well as have lower rates in terms of high cholesterol, as well as lower rates of high blood pressure as well.
Great. And I think you're going to talk about, speaking of Greece, like the Mediterranean type diet later on, so that'll be interesting.
Absolutely. Absolutely.
So what is the most common type of heart disease in the U.S.?
Well, the most common type of heart disease in the United States is going to be coronary disease. And specifically, that's when one has narrowing or atherosclerosis within the arteries that feed the heart muscle. And that's what we're all concerned about, because that does raise your risk of what's called a heart attack or myocardial infarction, a blocked artery per se. So that's one of the most common issues that we deal with every day in the hospital setting. And we definitely want to be more preventive strategy, and that's where risk reduction is so important.
Great, thank you. And I think you're going to talk to us, and I'm not going to interrupt you so that you can get through them, about various tests to evaluate heart disease or diagnose heart disease.
Absolutely, absolutely. So when we're dealing with the heart's a big muscle. I'll just get my little arrow here. You can see this is the heart right here in the center, and this is the heart muscle. And any muscle of the body has arteries that feed it. So here you got a picture of the heart. Here's the right coronary artery coming here. Here's the left main, LAD, and circumflex artery. So these are the arteries that feed the heart muscle. So when we're born, those arteries look nice, clean, and pristine. Here's a normal coronary artery. But as we age, and all of us this occurs, we get plaque that builds up in the walls of the arteries that supply the blood to the heart. And these arteries are called coronary arteries. And this plaque, you can see this little yellow stuff here, is made up of cholesterol and other substances, and they deposit within the walls of the heart artery. And this buildup process is called atherosclerosis, plaque or atherosclerosis. And over time, over time, there's actually more and more plaque that develops. And after a critical amount, usually about a 70% blockage, people start having symptoms. And we'll talk about symptoms in a little bit. And then two, if someone has some atherosclerosis where there's a blood clot, there's no flow going across the artery now, and those patients will have what's called a heart attack. Less frequent than atherosclerosis is called coronary spasm, where we actually don't have a problem with atherosclerosis and plaque per se, but some people, for whatever reason, have more prone to create spasm. There's a little bit of muscle layer within that coronary artery, and it can tighten up or cramp or spasm up, and they can get coronary vasospasm. So those are some of the ways that people can have coronary artery disease. And the process, again, when we're young, we typically don't see it, but as we age, we see more people with atherosclerosis.
Do you think that women are more likely to have one type or the other as far as atherosclerosis versus the spasm that you talked about?
The way I would approach it, I do see more coronary vasospasm in women. I think as people, and especially younger women that are younger, we do also see it more so in smokers as well. But I think as people age, we typically see more of the atherosclerosis where there's actually plaque buildup within the walls of the heart arteries. But yes, there is a little bit more predisposition of women having coronary vasospasm, as well as those who smoke cigarettes as well.
Got it. Thank you so much. All right. Yeah, so I think you're going to get into diagnosing. Thank you. Go right ahead.
No problem. So how do you diagnose a patient that has cardiovascular disease or coronary artery disease? Well, the first thing you want to do is find out what one's risk is. And that's a big part of what we do as cardiologists, is figure out what's one's risk. If you have someone that's 20 years old with asthma, doesn't have a lot of risk factors, has shortness of breath, you're probably going to pin that particular shortness of breath on their asthma, and to be less likely related to cardiovascular disease. On the flip side, if you have someone that has high blood pressure, high cholesterol, elevated blood sugars, and they also have chest pain or chest discomfort or shortness of breath with exertion, you're going to have to think, hey, this person may be more at risk of having coronary disease or a blockage or what have you. So with that, it's always going to be important for people to get their blood pressure checked, to know what their risk is, get their cholesterol checked, as well as their blood sugar levels checked as well. Things like being overweight, unhealthy eating habits, being inactive, cigarette smokers are all risk factors for coronary disease. And also family history also increases your risk as well, especially if there's someone who's had a family member who's had heart problems in, let's say, in their 30s, 40s, 50s, younger in age. If someone has a sibling who had heart problems in their 30s and 40s, a parent, those are first-degree relatives, that risk is going to be more so for that particular person.
Wow, that's great. That's great information.
Mm-hmm. Now, moving forward, these are the tests we use to evaluate heart disease. In cardiology, we typically work non-invasively and then become more invasive. So, and each test has their role in terms of being giving the right information, and those tests may not give the information you want. So there's always a reason why we do certain tests. So in terms of one's EKG, that allows us to see what the heart rhythm's like. But also in the acute setting, it can be helpful in diagnosing heart attacks. A chest x-ray can give an idea of what's going on with the lungs and if there's any fluid in the lungs, the size of the heart. An echocardiogram, it can give us information about how well the heart is squeezing, what the valves look like, if there's any structural problems with the heart. We do this test called a coronary calcium score, which allows us to see how much calcium is in the walls of the heart arteries. As I said earlier, if you have plaque within the wall, that is a risk factor for cardiovascular disease. So what's nice about a calcium score, it can actually see how much calcium is in the wall of the heart artery. And guess what plaque does over time? Plaque calcifies. So we can actually do a CAT scan of the chest to look at the amount of calcium within the walls of the heart to get an idea what the person's cardiovascular risk is. We can do a coronary CT scan that gives us information about how well the blood flow is going through the heart arteries. It's pretty much a virtual heart catheterization, where it's a non-invasive test that's given information about how well blood flow is going through those heart arteries. I'm sure we're all familiar with stress testing. Plain old treadmill stress tests is a very good way to get an idea of what's going on with one's cardiovascular health. But sometimes we add imaging to a treadmill stress test, and we'll do called stress echoes, which is treadmill plus an echo, nuclear stress, which is treadmill plus nuclear testing, which we'll see shortly. And then there's stress PET, another more accurate way of looking at blood flow with nuclear testing. And then we also do what's called cardiac MRIs. Again, another non-invasive way, an MRI, to look at certain features of the heart. And depending on the situation, we pick one of these non-invasive tests to see what's going on. We do heart catheterizations. Of course, at Tanner, we're very busy in the cath lab. And then that gives us direct view of what's going on with the heart arteries. But it is a minimally invasive test. And then lastly, EP studies, ablation, and pacemakers. These tests get an idea of what the electrical activity of the heart is. And if people have irregular heart rhythms or slow heart rhythms, we can assess that more so by that particular test.
That's great, because I think it's good for everyone to know that being evaluated for possible heart disease doesn't always mean that you're going to have an invasive test or a cath, because you have quite a few tests in the armamentarium of your diagnostic ability. So that's great to know.
Absolutely, absolutely. And I'm going to share with you just some, since I'm the non-invasive imaging, one of the imaging doctors in our group, I'm going to show you some of the imaging tests that we do. So we'll move forward. So this is an EKG. Many of you probably have had an EKG where we put the electrodes on the chest, and it gives us a 12-lead EKG to look at the heart rhythm. But also we can see features on the EKG that may be suggestive of a previous heart attack, someone who's prone to having an irregular heart rhythm. And so we get little nuances about the EKG. A normal EKG doesn't mean everything's fine. An abnormal EKG doesn't mean something's bad. It just means that we have to get more information. The lower EKG is actually a pretty substantial EKG showing an abnormality. This is an acute MI or heart attack, where this particular patient has ST elevations, which is an emergency where we have to go in and open up the heart artery. You can see how this little EKG signal here is above this. So that means that this is an acute MI. So this is someone that has to go directly to the cath lab, does not pass go directly to the cath lab.
Wow.
Here's a picture of a coronary calcium score. It's a CAT scan of the heart without contrast, and we can see calcium within the walls of the heart artery. Again, plaque calcifies over time, and we look at different zones of the heart arteries. Here's the left main, here's the LAD, here's the circumflex correlating to different arteries, and we can see calcium within the walls. Having calcium doesn't mean there's a blockage. Having calcium just means that you have a higher risk. And we're actually able to see what one's risk is depending on compared to other people in terms of their age and sex. So someone with a score, let's say of 42, who is, let's say, 50, may have a different risk in terms of someone who is, let's say, 80 with a score of 42. We actually can look at that and get an idea of what that person's particular risk is. So it's a nice, quick way of getting that information about cardiovascular risk.
And all the tests you're talking about are done right here at Tanner, right, Dr. Greene?
Exactly, exactly.
Right.
And actually, the coronary calcium score, you don't even need a doctor's orders for it. It's a $99 test that Tanner gives for screening. So you can actually just call there's a number for, I can't remember offhand, but there's a number you can actually call to get coronary calcium scores done. And these are one of the tests that we read here. So.
Thank you. That's great.
Here's a picture of an echocardiogram or an ultrasound of the heart. Again, a non-invasive way of looking at the walls, looking at the valves, seeing if there's any abnormalities from that respect. We can see if someone has a leaky valve, a valve that's not opening well, called stenosis. Here at Tanner, we actually can do 3D echo, so we get a 3D representation of how a valve will look, and it helps in surgical planning and gives us additive information in terms of how well the valve is working. So, okay. But this is just a little view of what the echocardiogram looks like. Many of you are familiar with nuclear stress tests. They go by different names: stress thallium, nuclear stress test, stress MyView. These tests are done with isotopes, not dye, but isotopes that are injected, and they selectively go to the heart. And we image your heart in two phases, one at rest and then one at stress. And we look at the blood flow differences between rest and stress to get information about how well blood is flowing through different zones of the heart. So these are very commonplace tests done to get an idea how well the blood is flowing through those heart arteries. If a test is abnormal, it usually correlates to a blockage that's greater than 70%. And that's the number we use in cardiology to get a sense of how well blood is flowing through different areas. If an artery is greater than 70%, it's typically fixed. If an artery is less than 70%, we typically those anywhere you go are not going to be open typically. Because it typically is not going to be enough to cause symptoms, and the risk-benefit ratio favors not to open up an artery that's less than 70%. But we want to keep it from becoming 70% over time, and so you want to control blood pressure, cholesterol, things along those lines. So,
great.
Here's a picture of a cardiac CTA. So what I like about this picture is that on the right side is actually a CAT scan of the heart artery. So here's the right coronary artery here it is, and it's coming around like this. So this is a non-invasive test looking at the heart artery. And on the left is an invasive test. Here's a catheter injecting dye into the artery. And so you can see how we can do a non-invasive test on the right to get pretty much comparable information about an invasive test on the left. So you can see how powerful these non-invasive tests are in terms of giving us, similar information with an invasive test.
That's great, and we're getting a great question that you could probably guess what it is. So why would you do the invasive?
Oh, yes. Well, invasive testing is usually it has a very low risk. So there's minimal risk doing a stress test, minimal risk doing a CAT scan. While invasive test has some, small, but there's a small risk associated with it. So that's why we typically will start non-invasively and then go work our way more invasive. So
the pictures of the CAT scan are so good. It makes people wonder, I think, why you would do a cath to get the picture on the left there. But I suppose also you can't put stents in or do any intervention with the CAT scan. So if you think you're going to need to do that, you would go to the invasive cath.
Mm-hmm. Exactly.
Gotcha. That was a great question that we got. Thank you.
Mm-hmm. And next up, this here is a cardiac MRI that just allows us to see how well again, it's like an echo, but a little bit more accurate, and can often add a little bit more information as well. So here's a picture of an invasive test, the cardiac catheterization. On the left side is someone coming in with a heart attack. And you can see how there's an area right here where I'm circling where there's no flow going or very minimal flow. And the patient, of course, was injected dye. We're looking at the arteries. And then here you can see how there's actually a stent placed. And there's great flow through that heart artery now. You can see the difference between pre and post-intervention. So there's someone that had a successful stenting procedure done, and the result looks great. So in the last picture, we saw someone that got stented. They reopened an area where there was an artery block. The stenting procedure involves a balloon with a stent on top of it that inflates through a tube called a catheter. And one of the things when someone's coming with an active heart attack, the key thing is to get the artery open as quickly as possible. We have a term in cardiology called time is myocardium. So the quicker you get an artery open, the better the patient does in terms of long term. So that's just a representation of how we go in there and open up a blockage via stenting.
So I heard that Tanner's door to balloon time, or time to get that artery opened, is better than the national average in the American College of Cardiology's guidelines. So is that true? And that's amazing.
It is. One of the things that we pride ourselves with is keeping up to date with some of the newest and latest innovations here at Tanner. One of the things that we implement is that when there's a question if someone is coming with a heart attack, as soon as the patient gets to the EMS, they can do an EKG, and that can be actually sent to the emergency room. In the emergency room, that can actually activate the cath lab in order to bring in, and that way the patient comes into the ED and goes straight to the cath lab in order to decrease those times. So that's one of the beauties in terms of having this technology that allows us to really act on things as quickly as possible. Again, time is myocardium, and our interventional cardiologist, Dr. Arant, as well as Dr. Kawaja, do an excellent job in terms of getting the artery open quickly, but also safely. You want to make sure that whatever you're doing, we're doing it in a quick way, but also a safe way. And then we've been, unfortunately, knock on wood, very fortunate in terms of having good times, but also a very low risk in terms of bad outcomes from procedures. We've done quite well here.
That's great news. I would much rather head it off early, like you're going to talk to us about, than end up in the cath lab. So your preventive talk and going over the risk factors is going to be really helpful.
Sure. Okay. So let's move forward, and we'll talk about the different risk factors associated with cardiovascular disease. And these are more specific in terms of people living in the United States. 2 out of 3 Americans are overweight or obese. More than 70 million, one in every 4 Americans have varying degrees of insulin resistance or diabetes, while another 54 million Americans have prediabetes. And these are all risk factors for cardiovascular disease. Nearly 1 in 4 U.S. adults have high cholesterol, and 1 in 3 Americans have high blood pressure. So in all, these risk factors are very prevalent within our society, and these are the things that we really need to spend more time in terms of educating, in terms of lowering these risk factor prevalences, so we lower cardiovascular disease in all. You can see here in the middle, we have cardiovascular disease, and these are all the risk factors. These are, the risk factors associated. You have lipid, high cholesterol, elevated blood pressure, diabetes, obesity, smoking, poor nutrition, being sedentary. The thing we can't really act on is family history in terms of genetics, but again, we definitely want to work on the things that we can modify.
Absolutely.
And then it moved forward into why should women be aware? Again, we're here talking about women and heart health. For women specifically, about almost 500,000 women in each year die from cardiovascular disease. That's about 1 per minute, unfortunately. And it kills more women than the next 5 causes of death combined. And 1 woman in every 3, 1 in 3, have some form of cardiovascular disease. So this is an epidemic. This is something we definitely want to, put a lot of focus and emphasis on, and we definitely want to work on decreasing the cardiovascular risk factors as we outline.
And I think you're going to tell us that living in the South is not in our best interest, possibly. Maybe we could modify that without moving, though.
Yes. So, Dr. Bowles, I trained up in New York. I've come, and from there I went to Maryland and D.C. And then coming down to the south, when I came here, they say, hey, there's a lot of cardiovascular disease. So I said, okay, I was excited. But again, it is sobering. It is sobering because the highest risks for cardiovascular disease are actually in the southeast, as you see from this diagram here. I think a big part of it is, some of the lifestyle as well as access to care. And it's important that we, have strong education incentives in order to tell people, hey, you got to cut down, be more active, eat more heart healthy, get your cholesterol to go. And those are things that, we all need to practice what we preach as well. Myself, I need to probably exercise a little bit more than I do, but that we all have to take the reins and do more for our cardiovascular health. Now, moving into risk factors, I touched briefly on these, but I just want to talk to them in terms and separate them between modifiable as well as non-modifiable risk factors. High blood pressure, that's something we can modify or fix. Smokers, tobacco use, something we can fix. High cholesterol, your numbers looking better. Physical inactivity, again, people need to, we all need to get moving more so. Being obese and overweight, weight reduction, there are weight reduction strategies out there. Diabetes has to be well controlled. So these are things that we can work on. We can fix these things. The non-modifiable, not so much. Increasing age, can't really do much about that. Being a male, hey, I got a risk factor there. Hereditary, your genes, you can't really do much about that. Certain races do have increased risk of cardiovascular disease as well. But we know the things that we can modify. And I think if we can focus more on these modifiable ones, then I think at the end of the day, we'll be in better shoes. Menopause does play a role in terms of cardiovascular health. After menopause, the risk does increase. And I'll touch a little bit more on that as well. Response to stress. Stressors sometimes can provoke cardiovascular symptoms. Excessive alcohol, absolutely. Increased alcohol raises high blood pressure. It can make the heart weaker, we call these cardiomyopathies and congestive heart failure. And certain illegal drugs, amphetamines, marijuana, they have negative attributes to the heart as well. So some things to consider as well. Hereditary, you can't change your genes, but unfortunately, there in certain races, there's a higher risk associated in Mexican American, Latinos, American Indians, Native Hawaiians, and some Asian Americans. There's increased risk for certain cardiovascular disease within those populations.
So, what should we eat? There you go.
Well, there's, it's almost like, what shouldn't we eat? But
that's good. Yeah. It's easier. What should we not eat?
I know. But, the way I approach it is that, you can't just say if it's good, don't eat it. You have to start someplace else. So, we want to use, eat foods that are low in saturated fat and sodium, eat daily recommended servings of fruit and vegetables. Fish is high in omega-3 fatty acids. That's been shown to be beneficial for cardiovascular health. Nuts, seeds, and legumes have been shown to be beneficial as well. And less meat is better. I mean, at the end of the day, we know places that eat less meat actually have lower cardiovascular disease. So, meatless meals 1 to 2 days during the week is beneficial. I've cut down on the amount of meat that I eat as I've gotten older. So I think these are all things that we can do to try to improve the bigger picture. And I'll touch a little bit about the Mediterranean diet, which outlines this a little bit more so. So first we'll dive a little deeper into high blood pressure. And again, it's called the silent killer. It's seen in women 20 and older. Within Caucasian white women, 32%. African American females, 47%. And Hispanic American females, 31%. So these are pretty high numbers in terms of high blood pressure, 20 and above. 1 in 3 U.S. adults, or about 75 million people, have high blood pressure. I mean, that's staggering. And only half, 54% of them, it's probably a little bit more than half, actually have their high blood pressure under control. So, 50 are doing good with high blood pressure, 50% are not. Our goals have been more stringent nowadays. One of the newer guidelines showed that you want to get your blood pressure on average, for most people, less than 130/80 on average. So, and again, you want to make sure you're checking your blood pressure when you're relaxed, an accurate blood pressure cuff. And again, when you see your doctor, that's why we typically check blood pressures on most patients when we see them, because we know that this is a pretty important risk factor that's quite prevalent, as you can see.
And it's pretty easy these days to check your blood pressure, right, and keep up with it as far as availability at drugstores, grocery stores, and even pretty affordable home blood pressure monitors, would you say?
Yes, absolutely. I think that's one of the things that from a public health, there's a lot of options out there, and not only getting your blood pressure checked in the office, but also with your own blood pressure cuff, going to the pharmacy, supermarket, or what have you. There's a lot of resources out there, so absolutely.
Great. And now the next topic, near and dear to pulmonary.
Yes. Oh, yes, Dr. Bowles. So smoking, oh my goodness, this is one of the tougher ones out here. It's probably the most preventable cause of death in the United States. And 18.5% of American women 18 and above smoke. So it's almost 1 out of 5, 20%. The risks have been known for a while. 1940, it was a report showing there smoking and heart disease go hand in hand. The first Surgeon General warning was in 1964. Different treatment options out there. There's, of course, you can do cold turkey to stop it on your own. Zyban, there's a newer drug called Chantix that's out there. Nicoderm patches, Nicoderm gum. Of course, there's peer pressure. Hey, you nudge, and you got to stop here. Support groups. Some people got benefit from hypnosis. There's a lot of things out there, and I tell people, the goal is to set a quit date. The goal is to kind of say, okay, I'm going to stop on this particular day and work with your doctor with it. This is something that's definitely can be tackled and won, but it takes a strategy, sitting down and knowing, hey, we need to do something to lower your cardiovascular risks, but also, Dr. Bowles, being a pulmonologist, your lung disease risk as well, correct?
Absolutely. Dr. Greene, you're right on target. Yes, and it's a tough problem to tackle. As we all know, nicotine is very, very addictive. So it's tough, and I used to tell my patients, like you did, set a quit date. But if you slip up, don't go back to half a pack or a pack a day. You slipped up, continue on with the quitting. Yes. It's tough, but like you said, you can achieve success.
Absolutely.
And don't forget, just for our attendees, please feel free to put questions or comments in the chat. All right, Dr. Greene, go ahead.
Next, moving into physical inactivity. In terms of women, Caucasian women, 22%. In terms of being inactive, African American, 34%. Hispanic American, Latino, 40%. So again, we all need to be moving more. We got these smart watches. We need to keep up with our steps. Use your Apple Watch. Use your what's the other one that's out there? Your Halo.
Fitbit.
Your Fitbit. There you go. That's the word I'm looking for. Fitbit, to get out there and walk and be active. Being more sedentary increases your heart disease and stroke risk. 30 minutes or more of activity on most or all days of the week would be the best scenario. And it's been shown to not only control blood pressure, but also controlling your cholesterol as well as diabetes and obesity. So all those things there's huge benefits just exercising and being more active.
I'll say, and how about the data that people who sit in their job all day have increased overall mortality, right? I didn't imagine that, did I? Isn't that true?
That is, and there's been a more push for people at their job to use these desks that are actually like standing desks, where they're less likely, they're not sitting down, and there's some benefit associated with that. Half the time in my office, I sit down so little when I'm walking around seeing patients, but sometimes when I'm reading a lot of studies, I have to remind myself, okay, I need to get up and, let me walk over here and so, especially when I'm reading a lot of studies like echoes and echocardiograms and so forth. So we all have to kind of look at our job and see ways that we can actually improve our own cardiovascular health as well.
Great advice.
So the recommendation, 30 minutes a day. 5 minutes of exercise may stimulate positive effects for the body. Running, walking, bicycling, basketball, dancing, swimming. Hey, the key thing is getting out there and being active. So, obesity, in terms of being overweight, obese, 20 and older, Caucasian females, 58%, African Americans, 79%, Hispanic American females, 73%. So you can see those numbers are quite high in terms of 20 and older. Childhood obesity rates have drastically increased. And I think a big part of it is us being more sedentary, and our diet is changing. There's, I hate to say there's more fast foods out there, a lot more food options per se. And the treatment's going to be a balanced diet and regular exercise, measuring your BMI. And that's the ratio between your height and your weight. And most of the time when you see your doctor, they'll check your BMI, and they can tell exactly where you are in terms of being, if you're overweight versus being obese, or where you need to be in terms of your weight.
Great.
Okay. Oh yeah, this is just right on time in terms of the next slide. You can see here normal BMI is 18.5 to 24.9. And then overweight 25 to 29, obese 30 to 34, and extremely greater than 35. And more than 65% of the population is obese. BMI over 25 is considered overweight, and you can see how the everything kind of lays out in terms of the table here on the right. All right, and then we'll move forward to diabetes and heart disease. Again, another risk factor. When someone has diabetes and heart disease, it not only increases your risk, but those with coronary disease often have more difficult to treat coronary disease because the arteries become diffusely diseased. If you think about it, if you have an artery that has a blockage there that you go in and fix, it's that can be more easily done. But if the whole artery is involved, it's diffusely diseased, it's a lot more challenging in terms of fixing. There's less treatment options out there, so it actually makes it more difficult to fix at times. Diabetics have more disturbed lipid metabolism, and that just means that they not only have diabetes, they don't metabolize cholesterol as well. So what ends up happening is they have higher triglycerides, lower good cholesterol, which is HDL, and higher total cholesterols as well. So diabetes and high cholesterol kind of go hand in hand, and by treating diabetes, actually you improve your cholesterol panel. They can have altered carbohydrate and lipid metabolism, again, interfering with the cholesterol numbers. As I said, reduce HDL, increase LDL. Diabetics with heart disease who have heart attacks often have worse mortality, and they can have unreliable symptoms, and I'll touch a little bit on that. Diabetics notoriously can have what we call silent MI, silent heart attacks. And just like we all know that diabetics are more prone to have numbness or neuropathy, where they don't have good nerves in their feet can cause numbness. The same thing can happen to the nerves that go to the heart. And so you may not sense the same type of pain or discomfort that someone else would have who doesn't have that neuropathy. So we see a lot of what we call silent MIs in patients that are diabetics because they're not aware that they've actually had an event. And there's one of the patient populations that have a high chance of having a silent heart attacks that we find out much later on.
So do they have, since they don't have the pain or the nerves cause that, would you say that they have other symptoms they should look out for, like the nausea or anything else?
Oh, absolutely, they can. I mean, I would say that most people that have heart attacks will have symptoms. I will say that diabetics as a group are the ones that typically have less symptoms. They can still have symptoms. But again, they can often have them if they don't have the chest discomfort. They may have the shortness of breath. They may have other symptoms per se. Okay.
Gotcha, but it wouldn't seem like a heart attack to them, so that's a really good point to bring up for people.
Mm-hmm. Now moving into heart attack warning signs, and in women, one of the most common symptoms in women is just a typical chest pain or chest discomfort. That's still usually the most typical symptom we see when there's something going on with the heart arteries in terms of a heart attack. However, women are more likely than men to experience more of what we call the atypical symptoms, where they can have pain or discomfort in one or both arms. They can have back discomfort. It's not uncommon up in the shoulder blades that are here. They can have neck discomfort, jaw discomfort, or even stomach discomfort, epigastric in the upper abdomen discomfort. They can have shortness of breath with or without chest discomfort. Cold sweats, nausea, vomiting, or lightheadedness can often be symptoms as well. One of the challenges is that I can probably find other conditions that can correlate to these symptoms. You know, if someone has jaw discomfort, you may say, well, it could be a heart attack, obviously, but it could also be something going on with your mouth or your tooth. So sometimes it can be very challenging with symptoms. So I tell people, look out for some new things that are going on. It's hard to explain. I'll often say, look for symptoms that are provoked with exertion. It's not uncommon that patients that have challenges with the heart, like a heart attack, will often have symptoms that are worsened when you exert themselves. And if you're not sure, go to the emergency room. Oh my goodness, you'd be surprised how many people I see who give very vague symptoms to us over the phone, who end up having something very substantial when they get to the hospital.
Well, you are so easy to talk to and such a wonderful bedside manner, and the education that you provide your patients is phenomenal. I wanted to see if you were up for a couple questions.
Absolutely.
And so, okay, great.
Absolutely.
So how would you approach EKG changes in women who've had, and this is a real technical type question, but I think you can help people understand. Women who've had bilateral mastectomies and chemotherapy, so maybe the chest wall is different. Would they have EKG changes, or would you be concerned about peaked P waves with no other signs or symptoms of cor pulmonale? This is a question. Could that be due to less impedance, I guess people are saying. So the women out there, and you really pointed out so beautifully that heart disease is the #1 killer, but we're all worried about breast cancer as women. So this is a great question, because breast cancer, thankfully, many women can survive, but the survivors, what does that do to the EKG, and should you be worried about that?
Well, I mean, I think what, one of the challenges with EKGs is that, they give us, information that can sometimes be additive, but sometimes the information doesn't always tell the whole tale. So I think any changes on your EKG, you try to explain it, so for instance, if someone, has had a mastectomy, and, what can influence the EKG is going to be the distance from the heart to the EKG lead. So if someone's had surgery in terms of mastectomy, that distance is different now. So yes, you can definitely see how the impedance or how the EKG could change with that. But, I take that with a grain of salt, so I think if I would act more looking at the changes that are there, but also see if I could probe and see if there's any symptoms associated with the person as well. Are they short of breath? Are they having chest discomfort, exertional fatigue, so forth? If they've had any type of chemotherapy agent that may make them more prone to a weaker heart, there's certain ones that can do that. That's where I would, probably probe a little bit more. A test I would probably tell the tale would be an echo, so if I saw an EKG, this looks a little abnormal, I may be able to explain it away by, by someone having a, breast surgery or what have you, maybe reasonable. Well, let's just get an echo just to make sure nothing's changed from all the, the procedures and so forth that's gone on with the patient with the treatment for the breast cancer.
Great, thank you so much. Here's a good question. I'll take this one so you can take a break.
No problem.
But would love to know if you agree. So do you recommend the Fresh Start tobacco cessation class that Tanner offers, and have any of your patients attended it and been successful? I'll say, and then you can, that yes, I recommend it, and yes, I've had patients attend and they are successful. It's a great program. You can get to that program by going to www.tanner.org and look at classes and events. Not only, and they're following social distancing and being careful during the pandemic. Don't be discouraged if you need a class and maybe some nicotine replacement. I have had patients who go to class and use the Nicorette gum and do very, very well. But they will talk to you about those options. Dr. Greene, have you had patients go to that class?
I have, and I've had some very good success. I think tobacco cessation is one of the things that kind of, when I see it, someone who's a smoker, who's had, stenting or any type of cardiovascular event, who I see regularly, it's not uncommon for me to, try to get them, nudge them, say, hey, okay, let's go with this program here. So, and I've had a few patients who have had some success there as well. So absolutely, I definitely encourage and have used it.
Great, thank you. We're getting some great questions. Here's one. Can a healthy diet clear plaque from arteries?
Oh yes, clearing plaque. No, we don't have I call that the holy grail. We don't have that as yet, where I say, hey, you take this, and if you had, let's say I had someone who has a 30-40% blockage, and I say, hey doc, how can I get rid of this? You know, it's tough to go back in time. You know, there's nothing we can say, hey, like take this to go back in time. What I usually tell patients, hey, I don't have anything right now that I can give you to make that go away per se. We're working on it in the cardiology world. But, you know, we know that intensive statin therapy, eating heart healthy, exercise, doing the right stuff, getting your cholesterol down as to really good targets can halt the progression. And so I think if we try to right now what we typically say is, can we halt the progression of disease is what we can shoot for. But hopefully in the future, we can do some things to actually cause regression or make things go back to where the plaque goes away.
Okay, great. That was a great question. So
Great
heart
question.
healthy eating and exercising would prevent progression. While it may not make it go away, you can keep it from getting worse. Okay, great. Well, that's a good segue to another question. How long should I be able to run if I'm fit? So that's a great question. And maybe you could talk about target heart rate. Is that still 220 minus age? That's what I remember, but I don't know.
It is. So, you know, I would say if someone is, and it all depends how fit someone is as well. I would say, you know, we use this formula in cardiology, 220 minus the age, and that's your maximum predictive heart rate. And then when we do stress testing, we try to shoot for 85% of that. When someone's exercising, we try to get to their target of 70 to 80% of that number. So a little bit below it. But I mean, I think if you're fit and very comfortable, I don't feel people should limit themselves in terms of how much or what target their heart rate should be at. I think as long as they're comfortable exercising to getting above that, I'm okay with it. Now, if it's someone that's older who, you know, may have some other health issues, you may not want to be that aggressive and get their heart rate up. But someone that's younger, fit, who wants to exercise, I mean, I think, you know, using 220 minus age is a good starting point. You know, maybe shooting 70-80% of that. But if you go beyond that, I'm okay with that as well. And because everyone's heart rate set point is a little bit different. So. And
running, I think, as your form of exercise, you would go back to the 30 minutes a day most days of the week, right?
Yes, absolutely. Absolutely.
So somebody may be able to run a few miles in 30 minutes, and somebody may do less miles. But also for women, I think it's a great thing to point out that weight-bearing exercise is good for their bones and to prevent osteoporosis or worsening osteoporosis. So even if you can't run, because I think knees can start becoming a problem as we age, and I know myself personally, I can't run anymore or jog, so I do cycling, but I also try to walk because I want to get that weight bearing in, right?
Absolutely. You know, the osteoporosis, you know, I'm more biased thinking more cardiovascular or doing more cardio workout, but that is probably just as important in terms of keeping those bones healthy, less fractures in the future, working on your balance. All those things are very are beneficial in terms of your global health. So yes, absolutely.
Great, thank you. And this is a great question, and I think for women and heart disease, is there any specific advice you would give for women to avoid heart disease compared to men, or is there something that women need to do differently, or does this advice apply to everyone? I guess that could bring up the controversial type topic of postmenopausal hormone replacement. Does that help? Does that hurt? And we may not want to get into that, but in a nutshell, you might say it needs to be discussed with the GYN, but what do you think for heart, women versus men?
Yeah, I mean, I think that I can't say there's anything specifically that's different. I would say that, you know, women can present with heart symptoms more atypically than men. I would also say that hormone replacement therapy is individualized. So if someone is having, you know, I wouldn't do it to prevent cardiovascular disease, you know, say I take this hormone, but if someone is having symptoms, you know, if they're having, let's say, you know, like hot flashes, but, you know, working with your GYN, because that is very controversial right now. So I usually stay out of that mix there, but I can't say there's one particular thing. We kind of make judgments sometimes based on on looking at the risk factors, hard data. So if your cholesterol is this, your blood pressure is this, your diabetes, those are more hard, tried and true risk factors. So that's what we put more focus on, I would say.
I think that's an excellent answer, and thank you so much, because I think that that's going to be one of our key take-home messages, is know your personal risk, and that may be the first life-saving step to keeping your heart healthy. And you just pointed that out again beautifully, that know your blood pressure, know your cholesterol, know your blood sugar. So what would you, I guess, just what other key take-home messages, now that we're wrapping up, and it looks like, please get your questions in. Right now, the queue, we've answered them all. So before we end, we'll just let Dr. Greene give us a couple of key take-home messages, if you would like. And you may have already said them, but let's hear them again.
Sure. Well, I think in the big picture is knowing your cardiovascular risk factors, and then doing your best to control them. We obviously, I can't change being a male, because that's a cardiovascular risk. I can't change my age. I'm not 29 again. I'm getting up there. But what you can do is, hey, if you know what your blood pressure is, make sure it's well controlled, less than 130/80. Know what your cholesterol numbers are. Work with your primary care doctor or your cardiologist to know what your targets are going to be. If someone's been stented or has had bypass, the target's a little different if you're 40 without any risk factors. Know what your weight and your height BMI calculates to. Have targets of where you want your weight to be. If you're a smoker, if you're a smoker, you want to work on cutting down and stopping. Get on a plan, or get on a quit plan in terms of coming off the cigarettes. So in all, you want to make sure that you're lowering your cardiovascular risk. If you're someone who has, let's say you have a strong family history, let's say you're 50, have a strong family history, and you want to know, okay, I know what my cholesterol is, I know what my blood pressure is, I'm doing okay, but you want a little bit more information. Maybe get a calcium score, maybe get that screening test for yourself to kind of know, all right, my score is a 0, or my score is pretty low, I know my risk is low. So again, you get as much information about your cardiovascular health, because it is the biggest cause of death in America. So you definitely want to know your numbers, know your risks, and be proactive.
Great. That was a great wrap up. Thank you, Dr. Greene. I just want to remind everybody that Tanner Heart and Vascular has multiple locations in Bremen, Carrollton, Villa Rica, and Wedowee. You can go to tanner.org/heartcare. You can also check out tanner.org again for classes and events. You can follow Tanner Heart and Vascular Specialist on Facebook. You can check out The Scope, which is Tanner's blog, via the website or at thescope.org. And I think that this has been a great Microsoft Teams live event with Dr. Onaje Greene, the best bedside manner of any cardiologist in the world. Easy to talk to, explains things well, and it's been an absolute pleasure. I hope everybody enjoyed this. We really thank you all for attending, and encourage your friends and family to take a look at this when we post it on Facebook as well. And just any closing comments? Again, Dr. Greene, thank you. You have been absolutely fantastic. A lot of information that you shared, and we really appreciate it, and we appreciate everybody attending.
Pleasure being here, Dr. Bowles, and thanks again.
All right. Thanks, everybody. Good night.